Hello, everybody. Thank you for joining us for Systems for Action's Research in Progress webinar. My name is Chris Lytle. I'm Deputy Director of Systems for Action, which is a national research program of the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. A little bit about what we support: studies examining multi-sector collaboration across medical, social, and public health systems for the goal of improving population health and achieving health equity. So today we'll hear about a follow-up study of a previous SFRA project. It assesses the capacity of community social services organizations to absorb new clients identified through emerging social determinants of health screening and referral tools used by medical providers during the COVID-19 pandemic. So let's move on to the next slide. So the way this will go today, we'll hear a presentation from the research team, Cameron Hodgins and Danielle Barda, followed by a commentary from John Ennis. Feel free to add any questions that you have throughout the presentation to the Q&A box at the bottom of your screen. We will reserve some time at the end for our presenters and our commentator to respond to those questions at that point. So feel free to add a question as soon as it comes to you. So with that, I'll introduce our presenters for the day. Cameron Hodgins, Dr. Cameron Hodgins is CEO and Executive Director of the Glasser Schoenbaum Human Services Center in Sarasota, Florida. It's a 5-acre campus of 14 buildings that houses a collaborative community of 20 nonprofit organizations as tenant partner agencies. The mission of the center is to connect, support, and sustain a network of human services nonprofits for a stronger community. Next slide, please. And Dr. Danielle Barda is an associate professor at the University of Colorado, Denver School of Public Affairs. And she's also CEO and founder of Visible Network Labs, which is a network data science and technology company offering software and services to leverage individual and systems level networks. She's also the author of the RWJ funded partner network science software tool, which is pretty interesting. Next slide, please. John Ennis, the Senior Vice President of Collaboration and Impact for Charles and Marjorie Barancik Foundation. He's part of a team committed to promoting meaningful changes in the areas of education, humanitarian causes, arts and culture, the environment, and medical research. So with that, I will pass things along to our presenters for today.
All right, Danielle, that's you.
Great. So I am having the great privilege to start this webinar. Thank you, everyone, for joining today. This is always one of the most fun parts of the work that we do, is getting to share and disseminate it. But I am going to let you all know that I'm going to pass a little bit back and forth with Cameron today. She is the PI on the project. The Glasser Schoenbaum Human Services Center is the partner that we work with. And I'll kind of walk through our focus of today, but we are talking about carrying capacity to absorb social determinants of health referrals. And by carrying capacity, we mean what is the capacity of the nonprofit and public sector and private sector to absorb the increasing referrals of social determinant of health screenings coming from systems. So the way that we're framing this problem is really to look at what factors are part of the system that determines that carrying capacity of the community. And what we know is, to kind of define the problem, is that the current system is made up of both, on one side, hospitals, clinics, and other social service agencies that screen and refer patients and clients out into the community of resources for referrals to meet their needs. And right now, the current system is already doing that. And what we know about the carrying capacity of the community is that, and if you've worked in the nonprofit sector or are working there now, you know how difficult it is to predict the need as it's coming and then to fund that need. So a lot of the funding occurs through grants and one-time funding mechanisms. So it's very difficult to predict an influx of those referrals coming. But on the next slide, it shows kind of what's happening now. So I always talk about how we've kind of moved mountains in the health and clinical setting area of understanding what it means to screen on people's social and economic needs and how that impacts their whole health. And so as hospitals and clinics and social service agencies are becoming more accustomed to screening on social and economic needs of people, in addition to their health screenings, we are now seeing increased referrals out into the capacity, which means that there are capacities that are already strapped that are getting pushed to the limits. And what we are really focused on is that community caring capacity side to understand what is it that can help us increase the capacity of that community to absorb those referrals, because what we know is it is a system, and if there isn't a mechanism that is looking at that side of it, the whole system is going to fail, because we can screen all we want, and as we refer out to the community, if they cannot absorb those people and the needs, then the whole system will fail. And there's a big question about finances and funding this work, because if the health systems are saying we're in a cost saving kind of strategy, and that, you know, creating whole person health strategies is going to save the system money in that regard, you know, there's a question about, okay, well then how are we funding the caring capacity of the community-based organizations to provide those services? And is there a funding mechanism that can either be innovative to fund that or transfer some of that cost savings from one side of the system to the other? So that's the big question. And on the next slide, so we are part of a brand new grant. I mean, I say brand new that we were awarded in November with our partners at Glasser Schoenbaum. It was an extension of our previous work. So prior to this, we came together as a team that basically asked this question and attempted to answer it in Sarasota, Florida, and Denton, Texas. We're going to kind of explain how we came together in a later slide, but I'll talk just for a minute about what we learned from that project and what was valuable to the communities that we studied. And what this grant is all about is a follow-on to that, which said we finished that study and we finished all of that network analysis work. And now, because of COVID, we have this really unique opportunity to ask that question in a pandemic a pandemic response environment. So on the next slide is just a little bit about how we answered some of those questions. The point of this is not necessarily to go through all those findings, and yet we haven't started and gotten deep into our data collection for this new grant. So we're kind of in this limbo place for presenting this. But what we found here, we really looked at how these cross-sector interorganizational networks of health and clinical agencies and community-based organizations were implementing screening, referral, and follow-up processes. So what you're seeing here, just some maps and stuff from our Sarasota work. And I mentioned that we also compared this to Denton, Texas. And what you're seeing here in the first picture is just a network map, and these can just look really confusing and like spider webs, and we understand that. But what's helpful in this map is all of the different colors, because you can see how many different organizations were part of this network. And we did bound this network around housing to try to understand, who would be a part of the network that we were asking questions from and about. And you can see that breakup in the pie chart next to it. So we just pulled out one little finding here where it says figure 8. On the left is a network map of those that said they do client assessments together in partnership. And then on the right was one that says client referrals. We can share these slides after if anyone is having trouble reading it now. So what is interesting about these two comparisons, and it's just a visual, and of course in network maps, it's, I always say the network maps are just the front cover of the story of your network. It's all the data behind it that's interesting. But here you can see that when we were asking about these referrals, there are a lot more people who are doing referrals to each other and not necessarily sharing assessments. So this is a problem anyone who's in this field will recognize, is that there is not a lot of shared assessment happening, which means patients and clients are being screened with different assessments over and over again. So this created right away an area that we could see for rooms of improvement and cross-sector coordination that could improve the system and flow and capacity. So on the next slide,
Come on.
Cameron's doing the slide today. So we asked just other non-network questions, and this relates to our follow-up study. So for example, we asked the organizations what their perceptions were of their ability to quickly expand services. So if they got an influx of really great screening coming out of the health system, how would they be able to absorb that? And you can see that in both sites, most people said a fair amount, only some a small amount, no one really said not at all. And then we also coupled that with a question around perceptions of financial stability, and you'll see an overwhelming response around very stable and stable. What was really interesting is we compared a lot of these data to their actual 990s when they were a nonprofit, and what we found was that their actual financials do not show very stable, and organizations in comparison to the perception that they could expand quickly. And sometimes I've worked in the nonprofit sector for so long, and sometimes I think it's our almost good-natured mission-driven conviction that we will help everyone who comes our way. So it's a real interesting look in terms of perception as that compares to the reality of finances. But on the next slide, what's happened is COVID hit, right, in March. And suddenly that question became real. Here is an influx of need. We were able at VNL to already launch a couple of surveys where we were able to ask some questions about COVID and whether people were able to provide the same level of services or more. So this slide you're seeing here is from actually a different network. But in this study, what we're really focused on is how well the community is able to leverage the network in place to respond to those needs. And I'm going to pass it to Cameron and just tell one really quick little story. Is right in March, when all of this was happening, we had just recently finished our project, and I got on the phone with Cameron and our partners in Denton, and I was so curious. I was like, what is going on in the community? And they just started telling story after story of how, because this network existed, because this network was already in place, they were able to quickly activate it. And in fact, their roles as shared nonprofit centers, they were able to be the coordinator, be the bridge and the hub for that work. And that was so striking. And that's actually what led us, when the call for proposals came out to study that, it was such an obvious fit, because they were telling this story that we could tell was really helping us understand capacity in communities to absorb this extra need quickly because of the network. So I'm going to pass it off to Cameron now.
So here we are now, and thank you, Danielle. That was a great background from our first project to where we are today with our new S4A grant. So now we're looking at how COVID-19 has impacted that alignment between our health systems, our public health services, and our social service referrals network. And have those increased? How have they changed? How have they morphed? Maybe how they've decreased? But how has Sarasota been able to activate those existing networks to increase the capacity and the resiliency and all of us responding to increased demand and referrals? So when we wrote the proposal, we had 4 aims, and I'm not going to read these word for word. You can look over them while I'm speaking, but the first 2 here are really going to be focused on the data that we're collecting. And then the last 2 are really more interpretation of the data and how we can use it here in our community, what lessons we've learned, what the cross sectors look like, and then what could we, how can this data help other communities possibly respond to, gosh forbid, another pandemic or public health crisis? And those of us that are providing that community-based services, how can we best partner with traditional healthcare settings? So Danielle's team and my team, we really like this Venn diagram here showing how community-based partners and research partners come together. And that synergy there in the middle is where we think our power really lies. And, like Danielle said, and I'll tell you the story of how we met in the next couple slides here, but we are more than just a research partnership. We actually are personal friends. We know each other's families. I know her team very well, and we live many, many states apart, right? But to me, all of this, and I've been on other S4A conversations this year where academic settings are asking, how do you form community-based partnerships? And I don't know, Danielle teases us and it tells us it's something that we take for granted, but this is what it's all about. You know, we need your academic brains and expertise and research platforms and data systems to help us better quantify and qualify the good work we know we're doing, but we often don't have access to that kind of technology or the funding, thank you, Robert Wood, to look at these systems the way that we really need to further refine and develop them. So there in that center, you see that the project development and design hand in hand with Danielle and her team. Interpretation of findings, again, just complete partnership there. And you know, like any relationship, not everything is easy to say, right? But we are very honest with each other. I think that's really key is, you know, and we know our community best. Hey, this is not going to work for our community, or this is. And Danielle and her team are consistently responsive to that. And then vice versa. They tell us what their data can and can't do for maybe some of our pie in the sky ideas. But I'm most excited this time around about getting the research back out to the community in a timely fashion and something that can really help improve the work that we're doing here. So what's the challenge, and how do we conduct research projects that benefit and partner with our community? And, you know, like I mentioned, I think the challenge is creating those unique and authentic partnerships between research individuals or research departments and community-based organizations. I believe that, yes, this is where I get to how we met. Always a fun story, right? So the Glasser Schoenbaum Human Services Center is 31 years old this year, and we are not alone in sort of our shape and form. We are a nonprofit center made up of all human service nonprofits on our campus. So the reason that's important is, you know, there's lots of sectors of nonprofits, but we are intentionally just human service driven, and that was twofold. One, for one-stop shopping for a person in need or a family in need, and two is we support the overhead operations of all those organizations. So they have a discounted rent. That's a good deal in our market, and we provide most overhead expenses for the occupancy as well as grounds maintenance and all of that. The reason that's important is because there are a number of nonprofit centers throughout North America. This is a very common model in Canada, so we have a lot of partners in Canada, and many of us are members of something called the Nonprofit Centers Network, and they are based now in California, but they used to be in Denver, and in, I don't know, Danielle, was 16 or 17 that they put out the first RFP through the Nonprofit Centers Network for our original Robert Wood funding, that project in 2017, and I responded because I thought, wow, this really helps. Of course, I'm thinking about it from a fundraising perspective too. This really helps articulate the purpose of our campus and measure the relationships that we have, not only on the campus, but in the community. And that's a difficult thing to do. So Danielle's team was brought in on that too. And Danielle, that's how we met too. Did you want to add anything to that story?
No, I think one thing I just wanted to make clear, Cameron and I talked today about this presentation and how to talk about doing this kind of research as community partners, because we haven't started or we haven't finished collecting all of the data for this second grant. But Cameron, you said that we know each other's families, but we only met each other through this project. And I think one of the things that we've learned as researchers is that as we do especially complex systems work, there's an important role that researchers play, which is the data and the science and this kind of thing, but we're only really half of this team. And so we really depend on the relationship with the community partners to be able to put the context on that story. And so for example, when Cameron was able to, and as they are right now, able to articulate how this capacity change is happening in the community to respond to the COVID pandemic, it's really something we couldn't get our hands around unless we had this very interesting relationship. And in both cases, for both grants, we wrote the proposals together. So we agreed to partner together before the funding happened, so that we could put in a proposal that was jointly written by both of us. And this time, Cameron is the PI on the project intentionally, because we wanted to be sure that the community organization played that lead role.
Right, and I just wanted to quick mention the reason Denton, Texas was involved in that first study is because they have a similar nonprofit center that looks a lot like ours, that houses their FQHC as well, and their demographics of their community were similar. So from Danielle and her team's perspective, we were two similar type communities struggling with two very intentional issues of opioid overdoses and housing issues. So that's why they were included also in that first study. Okay. Sorry about that. So, another thing that I think is a pride point for our community here in Sarasota is we have something that I'm calling micro networks that already exist in service provision. And I mentioned that Nonprofit Centers Network, and we're the only nonprofit center here in our community, but they provide a resource of just assistance all the time in what we're doing and how we improve our operations. So First 1,000 Days is a unique initiative funded by the Charles and Marjorie Barancik Foundation, which John Ennis can speak of in a little bit. And it is a wonderful initiative that's looking at mothers and babies, and from the days of conception to 4 years old, or whatever the first 1,000 days is, and how well our community is serving those families. They adopted the tech platform Unite Us to manage how we're providing services to these families. And if you haven't seen Unite Us, I highly recommend taking a look at it. It's really incredible. All families have access to it on their phone, on a computer, and the referral network is immediate and real time. And we can all see what the other organizations in the database are doing and how they're serving that family and the time it took them to connect with them, provide the service, close the case. It's really something. And it's increased efficiency and decreased time. And also that shared assessment piece that we weren't doing so well, it's going to help with that process as well. So real excited about that. Of course, we have the continuum of care for supporting our homeless population here, or services to the homeless population here. And the Community Alliance is just a group of nonprofit leaders and public officials and foundation leaders that get together once a month and also get together in different subsystems to talk about needs. Lots of organizations right now doing community needs assessments and sharing data, yay, we love that, and working together to create what data we may or may not have existing already. Our county government here in Sarasota County is quite involved in human services. They have a funding arm of the government here in which we can write grants and contracts to. And then a community foundation here, local community foundation, has a program called Season of Sharing. That's an emergency financial aid program, financial assistance program. In COVID, they have raised the threshold amount for each family to apply to within a 12-month window. It used to be $1,000 within 12 months, and now it's $1,800, and that was an immediate change because of the effects of COVID, and that's been a lifesaver for many families who are struggling to pay bills. And then, of course, we have 211 here that works for our region and is actually a call center in Orlando with a capacity to answer requests by text and chat too, and not just the phone call, which has really helped for efficiency purposes. So designing projects in partnership with the community. We do know what we missed last time, and I'm just really grateful to have another opportunity to redo this survey, add partners in here. We know we didn't capture the senior population very well, and I don't know how much you guys know about South Florida, but we have a lot of seniors, and so that was definitely an oversight. And this time we'll be also adding particularly COVID-19 vulnerable populations, and we know who those populations are and which community organizations in our community can give us the best feedback on those changes. And then any other organizations we missed last time. So I was just looking at the data set or the spreadsheet this morning. I think last time we had 41 organizations, and I'm up to 61 now. So that gives you an idea of how we're increasing the number of people who will partake in the survey. All right, Danielle, this one's you.
Okay, so we just wanted to round out the webinar and talking about our methods and how we're implementing them, especially in this partnership with the community. So what our needs are and our design is we are collecting information and stories right now. This is actually not a bullet on here on calling it a landscape analysis, trying to understand all of the from anything press that has occurred since COVID around the nonprofit response and public sector response, to the need to reports from different organizations and annual reports, anything that we're compiling together to understand kind of the story of how the community has responded. And then we will conduct key informant interviews with the community organizations to inform our partner survey design. And we implemented the partner survey in time 1, which was able to give us all of those metrics and data on what the survey or what the network looked like at that point and how it was being activated and leveraged and what was being exchanged. And then this time we will administer it again, really with a focus on how those relationships have been activated in the response to the increased need because of COVID. And so a couple of things we just wanted to add is what we do in this approach is really specifically community-based. So we do things like we design surveys with the fewest number of questions that will be able to answer all of our aims and research questions to reduce respondent burden, because we know that every time we ask a community member to answer a survey, we're asking them not to do something that's related to direct services. And so we want to be really respectful of their time. And it's really important to us to give the data back. And I'll show you what I mean in that in a second, and then translating the data to practice. And we couldn't ask for a better partner than Cameron and her team, because they are so good at this and have used from our time 1 the data in ways. I mean, I've presented to more groups in Florida than I would have ever imagined on a research project. But one example on the next slide of giving the data back is that we actually, we do surveys, and then we actually do create, like GIS maps and network maps and things like that. But what you see in the top kind of right-hand corner there of the slide is what we call a member profile. And so it's been important to us that when someone answers these surveys, we create these profiles for them right inside partner that basically summarizes where they are embedded in the network and where the whole network kind of looks around them. And this is called their ego network that you're seeing there, and then give them information. And then we print these out, we save them as PDFs, and we give them back to the respondents, because we think it's really important for the community members to have the data too. And so for that reason, we give them their own profiles, and we've seen them use these in annual reports or their own applications for funding. And so this has just been, and in this case, we know there's a capacity building aspect to understanding your role and position in the network and how to leverage that. And so that's really important for us. And then lastly, just to kind of round it all out, Cameron and I really wanted to talk about how important interpretation and dissemination is of the data and results, and doing that in partnerships with the community. So we just wanted to show you the examples of the ways in which we do that. We did it in the first project, and we will do it again now. And we talked already about continued collaboration between the research team and community organizations. We not only do that with the people that we work with in terms of collecting data, but we actually have regular meetings with this team where, the research team meets on its own. Of course, the community organizations are doing their work. And then we have regular meetings where we all come together at every point of the research. So designing the studies, getting the data, interpreting it, and there's nothing done in silo. We present to the community as often as possible and make the data accessible and easy to understand. And we have a real focus on trying to understand these policy and program implementation implications. And Cameron's been amazing at actually I've never as a researcher felt that our research was so useful in real time to communities, but it takes the community partner to value that data and take it back and put themselves out there as well to say to the community that they're going to share it and use it. So we just thought we'd show you these last few things. Of course, as researchers, we publish papers. So we published 3 papers on our first study, and with our team members, Todd Ely and Rachel Hogg, and Katie Edwards from the Nonprofit Centers Network. And these, ranged on just using network analysis to understand the role of foundations, which is something we were able to do, to really describing carrying capacity and things like that. So we have a qualitative paper and some network analysis papers. And then what we're going to show you here, and you can start it, Cameron, is Cameron invited me to come and speak at a gala, which is the fanciest I've ever dressed up to present research, in Sarasota. And it was on February 29th, right at the start of the lockdowns for the pandemic, my last trip I made. And what we're showing you here is a video reel that we made of this entire study to basically show to a lot of non-academic, not technical people. And the reason of course, I had kind of a speech prepared through this that was telling the story of our data and how, so this is our actual data kind of made beautiful in a way, and accessible in a way that we were hoping would communicate the strength of the network. And you'll see here in a second, there is a story that we were able to tell because of the data that we have, that basically revolved around this gentleman and his grandbaby, and how when they came to the community, they were able to access the network and leverage this. And we were able to talk about the capacity of the community there to respond in times of need. And so this was, as I said, right before COVID. And one reason we just wanted to share it was to give an example of how data can be made accessible and beautiful. In a way, I had people chasing me up afterwards saying, I have never come to a gala and seen a research presentation. And that was something that we're really proud of. So, last slide, I'll pass back to Cameron.
Yes, thank you, Danielle. And recently, our local major newspaper, the Sarasota Herald Tribune, published a paper, not a paper, an article, there we go, about the new grant we have. And then it was followed up a couple of days later by an editorial, which we didn't know was going to come out. And what that has done is created a lot of energy here in our community, and other nonprofits who aren't on the campus, I mean, we don't have 61 nonprofits on the campus, want to participate in the study and be a part of it, and then have further conversations with us about what the data can, how the data can help them. So really great energy, really good stuff, and we're so excited to get going here in the near future. And now I will turn it over. I think somebody was, Carrington, are you doing the intro? Oh, John we already introed John, so.
I feel fully introduced and I'm ready to take off from here.
So. Okay, great, thank you.
So first, thank you for that great presentation. And I want to stress as a funder how valuable this research has been for us. So the Brancic Foundation is a private family foundation. I used to work at a community foundation, and I know how valuable the work you guys have done has been for all of the organizations in Sarasota. Not every piece of academic research I've ever looked at has proven to be helpful and to move us forward in this community like this work has done. And that was, of course, the pre-COVID work, but it was clear how valuable it was when COVID did happen, how quickly Dr. Hodgins was able to get with the county and bring in other funders and say, we know we have a network, we know we have a system, research has proven it, now let's really amp that thing up and make it work to help the people in our community the best way possible. So that early research is what really helped us to do, I think, much better, I know much better than we would have done without it. So we already had the right players, we already had the communication established, and we had a good set of research to look back on to say, who are the most critical partners right away? We have to make sure in the room, in this conversation, to make sure we can really help our community move through COVID. And one of the things Dr. Hodgins said, I want to say again, is that relationships are certainly critical and important, and they're very valuable in our community. But in my experience, relationships don't always fix systems, right? Our system was broken in many areas, and many of us knew it. And I think the data helped us to present that to people who can help fix the system. So a lot of our work is systemic in nature, that the Unite Us platform that Cameron talked about is a way for us not only to make sure services are better, but to find out who's screwing up, right? If there's a backlog in the system, where is it? And we don't want to punish those folks, but we want to figure out how we can help them unclog that piece so that we can be more effective and efficient in our community. So that's a lot of the work at Barancik is at the systemic level, and we need that type of academic research so we're not just telling stories. Everyone loves a great story, but if you don't have that good data to back it up, it's really hard to move public policy. And the previous research got me taking a closer look at our county, for example. I was the chair of the Human Services Advisory Council that Dr. Hodgins mentioned, and our population has increased over the last 10 years, 13%. So Sarasota County's population increased 13%. Our health and human services funding decreased 2% during that same period of time. So we can all become very efficient. We can all get a lot better at what we're doing, but if you don't have any money to do the work, right, then we're gonna have a real problem downstream, and that has proven to be true. COVID, I love the slide Dr. Varda shared about what nonprofits thought they had in financial resources available. We frequently would answer the question when boards were asked us, how much money should we have in reserve? And when a nonprofit would tell me they had 90 days in reserve, I'd feel really good about that. And that was kind of our standard. I think I've changed my perspective on that now. I think you need about 2 years of reserve to feel comfortable because of how much money has actually been burned up because of COVID by our nonprofits. We called every single one of our nonprofit partners when COVID first hit and said, how are you doing? How can we help? If we had to repurpose a grant or fund something different or get some emergency funding to them. And I was so proud of some of our partners that said, you know what, we're good for right now. There are probably other nonprofits that need the support more than we do right now. Then 6 months and then 9 months. And now they're getting like, all right, we're out of, we're in a really bad spot. And this work that was done by S4A and by Dr. Hodgins helped us to the relationship part for sure, the network, and where are the critical pieces we have to make sure we're still investing in. I feel bad for our arts organizations, for example, like some of our funding could not go to arts organizations. I love the arts. I know how critical they are to so many things, but we were talking about people getting kicked out of their homes and water being shut off and people, not being able to feed their families. So going back to that diagram that I love so much, the spider diagram, to say, I'm curious to see how that will look different going forward. In the first round, some of those folks did share that they didn't feel good about where they were in that network. And there were some people that we funded and they were way out here and no one was connecting with them. And we've actually funded some positions at those organizations because I believe they're doing good work. They just not were able to respond because of capacity. So looking forward to questions, but I am thrilled with the work that has been done and the work that's going to be done in this next round and how much better it can make all of us, funders, the nonprofits that are providing the services, but also everyone that's interested. I love that the editorial in the paper, how much more interest, the people who I'd like to see, the ones that weren't in the network, why they want to be involved. And in some cases, we know as a funder, they want to be involved because they think there's future funding connected to it, right? How do I get in so I can see if I get money later on? But I know that many of those folks are, how can we do better in Sarasota with the cards we've been dealt? And we have a lot of work to do, as I mentioned, on the funding side. My last comment on Glasser Schoenbaum Center is when I go around the country and people, we talk about season of sharing or our first 1,000 days or the 2-on-1 or the relationships we have. People are so envious about Sarasota because we are so fortunate to have people that really do care. If you walk around Dr. Hodgins' campus and you see the names on many of those buildings, those are philanthropic giants in our community that said, we've got to make something like this happen. And I know they would be excited about what Dr. Hodgins has done to make it even more impactful. And we still have lots more work to do. She has so much space on 5 acres, but our county is long and we have a lot of room. We could do this work in South County and there's so much more we can do. And I'm looking forward to being part of that.
Thank you so much, John. So I see some Q&A here. Is it Chris? Are you handling the? Do you want to go through the Q&A?
Sure. That's what I'm here for. Thank you so much for this amazing presentation. So for the next 10 minutes or so, we'll go through Q&A. But I do want to go ahead and answer a couple of the questions that came in myself. There's interest in the studies that were in your presentation. Just want to let everybody know that you can find all of that on systemsforaction.org. Go to their project page. We have it all archived there. And also we'll share this presentation with everyone via email after this discussion. So I guess, so I'll start with, I'll use my moderator privilege and start with a question of my own. So there was Cameron, there was a financial capacity perspectives slide earlier, and actually I think it was Danielle who talked about this, and she mentioned the disconnect between perceived financial stability versus what was actual financial stability. And I'm curious what that actual financial stability looks like. How much in reserve should be there for them to, for their perceived financial capacity to match their actual financial capacity.
Yeah, so
or stability.
Danielle, I'll jump in there real quick. Since COVID, I sort of agree with what John just said about, we used to say 3 months, was pretty decent. And now I feel like it's 1 to 2 years in reserves. The other thing that I know was difficult for the, I think Todd Eli was working on that with Danielle's team the first time. Some of the 990s were tricky because for a large organization like a Salvation Army, their 990 was like their global 990, not the one that was here locally. So it was hard to see what their actual community capacity was just here as their own unit. And then the other piece that Danielle didn't show was an over-reliance on grant funding from the nonprofits in the first data set. And as you all know, that's tenuous, right? Like you can have it 1 year and maybe not the next. And how many eggs are you putting in that basket? So we were hoping to see more diversification in the funding, but it was definitely an over-reliance on grants.
Yeah, I'll just add on that. For anyone who's on the call who deals with the 990s, they're old, right? And they don't always have, not everyone reports. So we went down that path for some time, and then we realized this was a really challenging project to use that perspective on, especially, and also not all of the hospitals or clinical settings. Of course, they're not all nonprofits, right? So there's only limited data, but one of the things, and I will completely defer to the community members on the question of what should be in the reserve. That's the kind of thing I have not been able to answer through research. But one thing I did want to mention on that is, and I say this all of the time, but this is kind of my academic hat getting on for a second, but in the nonprofit sector, in the 80s, when the nonprofit sector really formalized and became a very legitimate sector, and courses at universities, that's the first time the sector had a real influx of money and funding, because a lot of the funding that was going into government services was now being channeled into these nonprofit agencies. That decentralization that happened during like the Reagan years. And since that time, there has been no new influx of funding except for what we all know going into the nonprofit sector, just grants and donors and fundraising and things like that. And something I think that's a very enormous potential for this work, this research, and this effort that we're all in on together right now is the next shift in the nonprofit sector of how funding can come in. Because if, let's say community-based or community dollars are having to be spent from nonprofit hospitals now, could that go into the nonprofit sector if the evidence is there to show that it's going to build the capacity to absorb those resources? And so I just find this to be an exciting time for the nonprofit sector, that maybe a new and innovative source of funding that maybe comes from payers or health systems or foundations, whatever it is that can come in, it could transform the nonprofit sector to go from from that unstable, very challenging place, if you've ever run a nonprofit place, to something that could actually complete this system and make a whole system that is actually going to work to address the social determinants of health. And I will just add, this is a little, you can tell my little soapbox, the very end is that it is, there's a huge moment here where we could also have a missed opportunity. And so if we don't address this problem, and if we don't get this data, and we don't change the way the nonprofit sector is financed, we will not be successful at this system that we are trying to build to align social services with health services and people and all of this. So, I can't emphasize enough that there is just such an opportunity right now to do some systems shifting work around that question of financing nonprofits.
Thank you, Danielle and Cameron. I'm going to direct the next question to John. Selfishly, it was a question I wanted to ask, and luckily someone else asked it in the Q&A. John, you mentioned moving policy forward. What, if any, policies were changed or moved forward in this project?
So from the policy perspective, one of the big projects we're working on right now is thanks to academic research, we have proven that our mental health care system in Sarasota is broken, right? Not like it's fragmented or like there's gaps. It is absolutely broken. We've funded research to have that proven in writing, right? So everyone knew it, but we had to get some research done to do that. And then the business community pushed back and said, well, wait a minute, you didn't ask these questions. So we brought on a national consulting team to answer their questions and spent some more money on research that everyone knew was already the case, but we showed return on investment, we showed where all the money comes in to fund mental health. And in March, on March 23rd, the first time our county commission was gonna put it on the ballot to vote to have a mental health taxing district. Then COVID hit and they decided, no, this isn't the right time to increase taxes for mental health because of COVID. Because I guess they had didn't realize that every piece of research I read said mental health is going to get worse after COVID, right? Not better. But so they delayed the ballot vote, didn't even give us a chance to vote on it. Now they do have the authority statutorily to just impose a mental health taxing district, a special dependent taxing district, and that made it as a priority for them this year. And in March, they will actually reconsider that. And I'm going to continue to hold up 3 fingers until then, because we need 3 votes. We feel like we have 2 right now, and we have the potential of a 3rd, and that could be a game changer, because the academic research said you will not fix this problem without a dedicated funding stream. Philanthropy is not going to be able to buy your way out of this problem. You need dedicated funding. So that's a policy thing that, based on research, has helped us to move forward, and I'm keeping my fingers crossed.
Thank you. Mental health needs during a pandemic, who would have thunk it? Yeah. So Cameron, we got a few questions about Unite Us that I'm going to try to combine together. Do you want to talk a little bit about how Unite Us factors in? And I believe you all use a separate system. So could you just talk a little bit more?
Yeah, so first I want to apologize for any confusion and just clarify that the first 1,000 Days initiative that was funded by the Barancik Foundation is the one who adopted the Unite Us platform for their initiative for first 1,000 Days. Unite Us is not being used for the project that Danielle and I are working on here today. But what was really interesting is our first study kind of finished up at the same time Barancik adopted Unite Us and moved forward with the first 1,000 Days. And I think our research helped John's boss know that we have a network here that's active and engaged already, and we weren't building a network from scratch. What Unite Us has done is further prove that that network is alive and well, and so partners are in that platform talking to each other all day long, primarily serving mothers and babies. And so that was a partnership with our local hospital. So there's a program coordinator for First 1,000 Days who is employed at the hospital, at Sarasota Memorial Hospital, who then works with these moms who are newly delivered. And the reason that we we focused on that is we found out there were quite a few moms showing up to deliver children without any prenatal care. And we just decided as a community, and John's boss decided that that was unacceptable and that we could do better. And so what was that lack of prenatal care actually doing to these families, or why were they disconnected and disenfranchised? So not only are we trying to reach them sooner during their pregnancy or even preconception about the importance of prenatal health care, but then continuing those services after the babies are born. And I can speak from experience, that's not an easy journey when you have a newborn. So I love this idea. So that's a separate project, but it was kind of happening at the same time that we were finishing up the Robert Wood study showing that we have these great networks here. I can let Carrington know more information about Unite Us for those of you on the call that are interested. It's a wonderful platform, and they're a wonderful company. And I know that multiple cities now in Florida have adopted it. I know that the entire state of North Carolina is going on it to manage their social service system, and I believe Utah. Does that sound right, John? I think it's Utah as well. And so Florida is slowly building together as a state, kind of one city, one major city at a time. They're particularly active in the VA systems around the country. The gentlemen who created Unite Us are veterans. And so when they came back from overseas, they noticed their own struggles with getting services and decided, hey, we can do better than this. The 211 piece, Chris, can I jump to that? Is it okay if I mentioned? Okay, so 211 for our community operates at the same time as this Unite Us, but the 211 system that is supported here serves 3 counties. Serves one just to our north and one just to our east. And so, and does traditional 211 resource and referral, like you probably all know. So the Unite Us is really just for that first 1,000 days program. But as you know, any family with one need typically has 5 or 6 or 12 others, especially right now. So Unite Us, the organizations on the Unite Us platform are branching out into not traditionally mother and child based organizations. Just to increase that web of referrals and support.
Can I just add, Chris, that I think when Dr. Barter and her team came the first time, Unite Us was, First 1,000 Days was coming up as one of the things that people were commenting about. And she actually asked a question about, they haven't made any referrals yet. And that's because we spent 2 years building a network, right, and getting it together. We hadn't even hired the person at the hospital yet to run the program. So her research was absolutely correct. We've got all this stuff happening in the community and we haven't referred a single person yet because we were still building it as we went. And now the referrals have started to happen and we've got some really amazing results. But that was something that we discovered way back in the first part of her work.
Well, and I just wanted to say real quick, so the person who's the program manager of First 1,000 Days this morning emailed me the list of partners that are in her database. And what we might be able to do is isolate those and look at their network within Danielle's platform, right? So they're excited about what we're doing. We're working together. We're talking to them constantly to see what that network looks like in the Visible Labs network system.
I actually remember we did that with the data set in the first round. We isolated the first 2,000 days network and looked at it as like a separate data. We didn't have all the partners in there though, because we didn't collect the data with that intention then.
Right.
So it was nice to be able to see the sub networks that we're forming, because what happens in a lot of network studies is there's a lot of redundancy. Like there's no system that is working without all these other community partners. So it seems a little silly to do a network study where you're not thinking of all the other networks that are embedded within that one. And so kind of naturally, we were able to take some of the data out and look at it in that way. And it, as part of the dissemination, as a communications tool to help the community understand the value of it and how we can do this in a way that could capture all of those aspects together. So that just made me remember that we did that.
All right, so we have a number of questions left, so we probably won't be able to get to all of them, but if folks have burning questions that we don't get to, feel free to share them to us, and we'll get them in front of the presenters and get those answers for you. So the next question, so how was capacity of partners, around on my screen. How was capacity of partners to provide services measured? They are assuming finances and FTEs, but was there anything else included in that formula or assessment?
Yeah, so what kind of made our approach unique was that we weren't just looking at capacity in terms of things like number of beds or even just funding, but what we were really trying to add is this network science perspective. So how do collaborative approaches and cross-sector partnerships actually increase capacity? And one of the first stories that we ever heard, and I actually think it was a Denton story, but when we were designing the project was an example of some food banks in the community that couldn't afford their own freezers, and so they weren't able to provide the level of food for the level of need. And so together they bought a centralized freezer, and it can increase their capacity because of their partnership in that purchase in order to be able to provide more food to the community. And so what and one of the reasons that we use this approach, a colleague and I years ago, I think the paper was published in 2009, wrote some work on how collaborative measures and approaches could measure carrying capacity of communities. So that was published in Nonprofit Quarterly some years ago. And so we used that to try to understand that in this case. And so what we were doing is, and also, so using kind of collaborative measures, but then also direct questioning. So being able to ask individual organizations as an attribute. So I'm kind of speaking methods language here, but as an attribute in the networks about what they are providing and when they were exchanging resources. So for example, a measure of capacity could be if there was a reciprocal exchange of resources to each other, could be considered higher capacity than even a one-way delivery and things like that. So that's what we were trying to do and will continue to try to do, is capture the relational and collaborative aspects of capacity through this study. And I think we'll be able to do it a lot more directly right now because we have this really specific outcome that we are looking at.
Chris, I want to just mention real quick, one of the biggest shifts we saw in this was partnering with our local hospital. And somebody wrote a question about this. And our local hospital really has come around to this idea of social determinants of health being a major indicator of overall wellness. And I'm native to Sarasota, been here a really long time. And this is the first time in the past 4 or 5 years that I've seen them kind of really pay attention to that. And it was led by the First 1,000 Days Initiative and the head of the Women's and Children's Department at that hospital. She got keyed in on it and thought, wow, we as a health service system, and they're large here, need to be looking at this more broadly. But before, it was very traditional, like, you're sick, you come here, you get well, goodbye. Yes, case management and everything like that, but they weren't, I don't know, John, tell me if I'm wrong, but they weren't as open to community partnerships as they seem to be now. That was a game changer.
I agree. And on the first 1,000 days, one of the very simple things is they added a question to the survey that they asked families as they were leaving about food security, right? It was simple to add one question to their survey as you're checking out, but it had to go through legal review and everything else to just say, are you food insecure? Them asking that question, able to link through Unite Us back to the All Face Food Bank to actually set up food deliveries for families that were food insecure. Such a simple thing that Dr. Hodgins is right. In the past, that would have been impossible, but the relationships and the research that showed how important these type of things are to the community, the connections, really was able to make that happen. And they have developed a whole system now where not only is food getting there, but where do they establish their food delivery and trucks and things like that based on the needs of the community instead of what they think, right? It's based on research. Here's where we can get the best bang for our buck, including at the Glasser Schoenbaum Center, where you have food delivery happening right there on that campus.
Right, and so there, in the database of partners that will complete this survey, there are multiple individuals from the hospital that will complete the survey because they're representing different campuses of that hospital or different community locations of that hospital.
Thank you so much for those responses. We have a few announcements, so I'm going to try to run through them in a minute. But folks definitely follow up with this with this study, check out their page on our website, systemsforaction.org. So if you want a certificate of completion for today's webinar, there'll be a survey at the end. We'll also email you one. And I do want to announce our next funding opportunity. So we are offering $2 million is available to measure solutions of wrong pocket problems. If you want to learn more about this funding opportunity, check out our funding opportunities page. We'll also have an informational webinar on March 17th. So please mark that on your calendars, check it out. Proposals will be due June 9th. And also, next slide, please. And then of course, upcoming webinars, same time, same place. Our next one will be March 10th. Using whole person care to coordinate health and social services for Medicaid populations. This is another one of our supplemental studies looking at the impact of COVID-19 on multi-sector collaboration. So thank you again to Dr. Hodgins and Dr. Varda as well. Really appreciated this presentation, and I hope everyone enjoys the rest of their day.